Today, we're talking about something so many women are experiencing, but very few were ever prepared for it, which is perimenopause. That phase where your body starts to change, your emotion feels unfamiliar, your sleep is off, your patience is thinner, and yet you're often told your labs are normal. And for many women, that leaves them questioning themselves instead of the system. So today we're having a real and honest and much needed conversation. I'm joined by Dr. Kudzai Dumbo. She's a board-certified OBGYN and a menopause specialist to help us just understand a little bit more on what's actually happening in our bodies and why the perimenopause is so hard to diagnose, how it affects our emotional and also vaginal health, and even how it can impact our relationships. Dr. Dumbo, thank you so much for being here. Well,
Yeah, you're welcome, Heather. It's a pleasure for me to be here.
thank you. All right, so Dr. Dumbo, again, why is perimenopause so difficult to diagnose?
That is an excellent question and a question that I get a lot from women. I think we're so used to like a blood test diagnosing diabetes, a blood test diagnosing high cholesterol, a blood test telling us whether or not, our thyroid is off. When it comes to perimenopause, what's happening in our bodies is quite chaotic. So blood work doesn't always capture like one, snapshot of blood work doesn't always capture what's actually happening in our bodies. And I'll explain it to you because it's a biological transition and that has real impact when it comes to the symptoms that we experience. And your blood work can show up as normal. So I'll start off by sharing the biology behind it. So perimenopause is a transition. This is a time frame where your body, like we know that menopause is 12 months without a period, but the time leading up to that can last anywhere from 5 to 7.4 years. Some women, it actually can last for 10 years. And during this time, what's happening in your body, like your ovaries, they've been used to a very steady state of, estradiol and progesterone. So they have like this, if you look at graphs, your estradiol level goes up in the first half of your cycle, peaks at day 14, and then it goes down. Progesterone goes up, once your estradiol goes down after ovulation and your progesterone, So there's a very delicate balance of how your hormones work when your ovaries are operating in what we call the pre-menopausal state. During perimenopause, what happens is you have this time of like chaos where your brain is trying to tell your ovaries, pump out more estrogen because I'm not picking up that you're putting out enough. So it shoots up and then it kind of comes down. And so you have this really chaotic time where your hormones can go really high, really low, really high, really low. And it's mostly, we see that with the estradiol and progesterone. So that's biology. So that's a transition time that occurs. And what happens is that as your body goes through this zone of chaos, by the time you enter menopause, there's an actual steady, we call decline in estrogen levels. So your levels start to go down and they just consistently go down until really they're pretty low or undetectable. And that is the time where we say that, once you've gone 12 months without a cycle, you've entered menopause because your estrogen levels have gone down so low that you're not even able to have a period. So I think it's important to identify that this zone of chaos that occurs in perimenopause can lead to very high highs in levels and then very low lows in estradiol. So the lows are when you start to have those menopausal symptoms.
Right.
Okay. And so, like, let's say you do a blood test, 7 a.m. today, you do another blood test at 10 p.m. the same day, and they could be completely different because you have that, fluctuations in your hormone levels. And they don't get captured simply by looking at just one test. You don't really truly capture what's happening in your body.
Okay. So, because this has happened to a lot of friends, even myself, when I first started feeling some symptoms and going to the doctor and they saw it, they said, no, you're not in perimenopause. But the way I was feeling, I was like, something is off. Are doctors not trained to know this about us? That,
So, yeah. So, I mean, I'm an obstetrician gynecologist, and I did my residency training during the WHI when this Women's Health Initiative came out in 2002. So that really, created a lot of fear when it came to, the treatment, hormone therapy for, menopausal symptoms. And so that kind of shut down like any kind of research, education, to a whole generation of doctors. So it was just deprioritized. Funding was deprioritized when it came to research.
Mhm.
It became something that was kind of put on the shelf. So a lot of us did not get training or education when it came to menopause. I did not know what happened in the body during perimenopause until like a couple years ago, like 5 years ago.
Mhm.
This is not like all the education that I've had to actively seek it out. It
Mm.
wasn't anything that was brought to me. I had to actively seek it out so that I could learn and know what was going on. And I had a lot of friends who were going through the transition,
Right.
and I didn't have answers for them. Like, I would be like, "Go find somebody you need to talk to." I was an OBGYN doing deliveries, surgeries, and you know what I mean? I hadn't been trained.
Mhm.
My suggestion to them was, you should probably find somebody who knows about this.
Right.
However, I also knew that I was probably gonna be going through it myself,
Right.
since I'm 52 now. And so it's just I guess what I'm trying to say is it's really the system that has n deprioritized, this as a result of, the study that came out in 2002, which really said that, hormones are harmful for treating, menopausal symptoms.
HRT, right. And I'm realizing now a lot of people are starting at a younger age with perimenopause. Is something changing in the system?
No, not at all. It's just we honestly, it's we did not know this data or this information, okay? All the studies, when you look at hormone therapy and, we used to call it hormone replacement therapy. Nowadays, it's the same thing as what we call menopause hormone therapy. All the studies that we have on, the medications are all on postmenopausal women. We have no
Mm.
data or very limited data on women who are going through perimenopause. So now we are looking at, oh, well, if the therapy works for women symptoms who are going through menopause, it should also work for women in perimenopause.
Perimenopause.
There's a lot of this is why there's just been this big explosion because women who are in perimenopause have noted significant improvement in their symptoms as a result of looking at some of those options when it comes to hormone therapy, which
Right.
again, we have no studies. You have to just understand that there are no studies. It's all done on post-menopausal women, women who are past menopause by
Right.
yeah.
Because that's what they were saying. So the studies before was HRT gives you cancer, so don't do it. But this test was done for people who already post menopause. Is that what this?
So you have to understand that prior to that study, there were several, like women were treated with hormone therapy like candy because they thought that this was a treatment that would help reduce heart disease. Like there was a lot of women who were being treated with hormone therapy prior to the WHI. And so then the study was conducted because they really wanted to see, hey, since we're really treating so many women with this, can we see if this particular medication or, these hormones can actually reduce the risk of heart disease. That was the
Okay.
primary reason for that study. However, unfortunately, the study was stopped because what they thought they saw was an increased risk of breast cancer. So they were never fully able to look at, um, you know, uh, what the premise was in the beginning,
Mhm.
but they did certain have some information because it was a huge study. It was a very large study, a huge population of women. And they did find that for women who were earlier on in menopause, the early on stage menopause, like your early 50s, those were women who actually had a reduced risk of heart disease. It's just that the average age of women in that study was 63. So you have women who've been past menopause, some of them for over 10 years.
Right.
So that's where a lot of the discrepancy came was that, when you did a little bit of a deeper dive, the data, was not really focused on, okay, women who are earlier on in menopause versus the ones who are later on in menopause. So they just lumped it all in one and basically said we need to stop it.
And you stop it. Wow.
Yeah.
Okay. So what I'm listening to, you think HRT is good for you to start at an earlier age once we start feeling perimenopause?
So
What's your
here's
thought?
what the data showed. I'm sharing this with you because it's not just what I think. It
Understood.
really has to be grounded in the data. And
Mhm.
what the data shows is that if you start, and all this data we were able to get from that, study, but if you start hormone therapy in what we call early menopause, which is within 10 years of your last menstrual period or under the age of 60, that is the optimal window of opportunity where you are more inclined to experience more of the long-term benefits of hormone
Sure.
therapy. And so when you think about the long-term benefits, you are looking at heart disease, you are looking at brain disease, or things like Alzheimer's. You're also thinking of your bone health, right? Like when it comes to breaking your bones, like osteoporosis. You're also looking at, just the SWAN study showed women, especially women of color, when it came to, the risk of diabetes and, like hypertension, women over the course of 20 plus years. And they found that women in middle age, and I think they started out with women between the ages of 42 to 52,
Mhm.
and they followed them for, 2 decades. And they
Mhm.
found that, you know, when you go through this transition of fluctuating hormones and a decline in your hormones, you are at a higher risk of developing diabetes
Wow. Okay.
and some of these some of these conditions that lead to cardiovascular risk. And we know that heart disease is the number one killer of women. So
Yeah.
if we know that heart disease is the number one killer of women, wouldn't you want something that actually would help reduce that risk?
Right. Right.
Yeah.
And since you brought it up, why is there a study showing why is it that Black women get menopause worse than white women, even diabetes and everything else? Is
Yeah.
there a study
So
showing
this
why?
is the SWAN study that I was just mentioned. So it's the study of women around the nation. That's what SWAN stands for. The study of women around the nation. And what it did, it was 3,302 women, I believe, that were in this study. And what occurred is that they made sure they looked at the entire United States. They wanted to make sure that they studied Caucasian women, Black women, Hispanic women, Chinese women, and Japanese women. They wanted to take a look at what are the differences when it comes to how these women go through the midlife transition, right? How do they go through the midlife transition from 42 all the way, to another 20 decades? What's happening in their bodies? What are they seeing? And all
Mhm.
that. And that's where they were able to find that, Black women experienced, hot flashes and night sweats, higher severity. The severity was more intense. They found also that the duration was longer. They also found that the time of menopause was earlier, like approximately 1.2 years. So the
Yeah.
time was earlier. And they also were able to identify a few key specific things. They were able to notice that, wait, when you look at the number of women who are going for treatment for depressive symptoms, for
Mm.
sleep symptoms, for some of these symptoms that actually occur, the least likely are Black women.
The least likely a Black woman.
Yeah,
Okay.
yeah, to be treated, to actually seek care for
Okay.
mental
Okay.
health. And even when it came to the actigraphy, and this is when they looked at sleep, because
Mhm.
sleep is another symptom that changes when you go through perimenopause. They
Mhm.
found that Black women didn't complain about having,
I'm gonna complain about it.
short sleep or not enough sleep. White women tended to complain more, but when they actually did the actigraphy study, they found that Black women had less sleep than white women. And
Oh.
for when it comes to sleep, that is one of the highest markers we look at
Mm.
for inflammation in the body.
Mm.
Inflammation in the body leads to all the chronic conditions, right? We're talking about heart disease, hypertension, diabetes, Alzheimer's disease.
Alzheimer's.
So that's where, they were able to directly correlate, that what they were seeing was also linked to like what we call C-reactive protein, which is a marker for inflammation in the body.
So is it just because of how we were raised type of thing? We don't complain about anything. We don't get seen. I just can't sleep and that's it, and just
I
chop
think
it up as it's nothing.
I think there's more of a normalization to like I just got to push through and the suffering is considered a normal part of life, but what they did actually do as well in this one study, they made sure that they called it a daily discrimination scale. So
Mhm.
they looked at all these different populations and they wanted them to rate what is your experience with discrimination, right?
Mhm.
On a day on a daily level. And with Black women, 57%, I think, reported experiencing, you know, discrimination, like, and it was based on their race. I think for white women, can't remember the exact number, but it was definitely lower. I think it was either in the 20s, and they reported gender discrimination, not so much, but they just determined gender discrimination.
Right, right.
And I think, it was really important that they identified, well, they did identify that this has a significant impact, right? The systemic, the systemic structures within our system that
Yeah.
lead to racism has, a significant impact on this.
Wow.
There was, the concept of weathering. I think you've heard the concept of weathering,
Mhm.
where, Black women, chronic stress, within our system leads to that higher incidence of chronic disease. So
Right.
there are a lot of different factors that they were able to look at and identify, which is why the SWAN study is definitely
Oh.
it's a collection of information, and there are a lot of studies that have broken down the impacts when you look at how this transition
Mhm.
experienced Black women versus a Caucasian women, Hispanic women versus Caucasian women, the
Mhm.
fundamental differences.
Wow. Okay. Wow. So I was going to ask about some of the symptoms that different people see because this weekend, tell me if I'm wrong, a friend of mine told me even the itchy ear is a part of menopause. Is that true?
Well, it can be, right. We always say, okay, so there are a lot of unusual symptoms that come with, perimenopause and menopause. So I think what's really important to identify that with this gap in medical education, this is another reason why perimenopause can be missed because some of the symptoms overlap with other, organ systems and other concerns. For example, the inability to sleep may not
Mhm.
necessarily be identified as, "Oh, this is related to, perimenopause." Sometimes like a lot of, anxiety, it can
Mhm.
be, talked off as, oh, there's just a lot of stress going on in your life,
Right.
or brain fog, not being able to communicate, concentrate, forgetting where you located thing, you left your keys, also forgetting words,
Oh, yeah.
those are also, symptoms. And so when women experience that, they may not necessarily go to a menopause expert, when they're experiencing
Right.
that. They may go to their doctor, with concerns about like, do I need to see a neurologist? Do I need to see a sleep specialist? And
Mhm.
then, do I need to see a psychiatrist?
Mhm.
Or some of the joint pain that occurs, right? Joint pain has not necessarily been one of the, foremost symptoms
Right.
that are identified with perimenopause, but
Uh-huh.
pain can be from the inflammation in the body that's occurring as a result of the fluctuating estrogen levels. So it can be a true symptom. But what would you do if you went to your doctor and had joint pain, right? They may send you to like an ortho, they may send you for an x ray, which
Some Motrin.
I think it's important that those kinds of things, I'm not saying that they don't need to be ruled out, but what I am saying is that when you have a cluster of symptoms,
Mhm.
after you've ruled everything out, don't just send a lady away and say, you're good,
Right.
because that could be related to, that collection be related to perimenopause. So I think this is why it's often missed because, women are sent all different directions. Oh, you need to go to the psychiatrist. You need to do this. And meanwhile, I mean, irritability is another
Right.
one. You're just
Mhm.
irritable, I mean, your family can be like, you need to go to the doctor or
Something's
something.
going on with
Heart palpitations, right? I think this was a big symptom that Oprah had talked about for
Mhm.
her. And a lot of women, I'm not saying you don't need to go and get your heart checked out, right? But if everything comes back as normal,
Right.
let's not just send you on your merry way and say, oh, you're good. Because you
Right.
know what? That is real. That is a real symptom. And so it's important that, okay, well, if it's not that, let's now try to investigate if it
Right. Right.
could be something else.
Right. And a lot of sorry, go ahead.
Go ahead. Go ahead.
No, I said a lot of people just say, "Okay, I'm just getting older. That's why my bones, my knees are aching like this," and they're not thinking it's something medically really going on too, right?
Biological phenomenon that's going on in your body, right? This is biology. It's not just you're being lazy. It's not just you're stressed. It's not just, your hormones are actively like fluctuating and going all kinds of directions. And I think it's so important for women to understand that this is treatable. Like suffering is optional. You
Yes.
don't have to like just muscle through because I
Right.
think there's something about us as women. I mean, I did that, but I think there's something about us as women that just thinks that, okay, I just need to try harder. I
Right.
need to just, you know, I just need to do more. And then we beat ourselves up,
That sounds about
when we
right.
feel like our body betrays us.
Right. And see, and that's the thing too. Even I know a lot of women don't even want to talk about this. They probably just deal with it silently, and it's about their vaginal changes as well. I know it's
Mhm.
a taboo. People don't want to talk because they're also embarrassed.
Yeah,
So I know I've heard a couple of my friends they talk about it's like vaginal dryness, the itching, the burning. I'm hearing odor changes as well, right? All of this changes with the hormones, even the painful intimacy, and they don't know what's going on with their body and maybe their husband too, or, the men also don't know how to deal with that when their
yeah.
wives or girlfriends change. How do
And
you
this is why it's important to talk about it. This is what I tell because I do some support groups as well. Like co-host support groups for Black women. And it is really difficult to because there's shame, right? There's shame, then you feel isolated, then you feel like something's wrong with you, and then there's it just is a snowball. But I think what I found is that when you not only realize that this is, again, a biological change that's going on in your body, something that you cannot help, right? You can't help this. It's a biological change when your estrogen goes down or even when it starts to fluctuate, right? And you have the dips, it can lead to less tissue elasticity in the vagina. So your vagina is less elastic. Lubrication, is reduced.
Right, right.
So, that tissue, why do you have odor? Because your microbiome, we call it, the normal bacteria in your vagina shifts when estrogen gets low, that
Mhm,
whole environment changes. So you
mhm,
may have, discharge or
mhm.
odor. And then your bladder as well. Like, why am
Right.
I feel like I can't hold my urine? Or why is it that, the moment I need to pee, I gotta run, or I'm leaking, or, I'm finding that I'm having many urinary tract infections,
That's what I was gonna ask,
right?
yeah.
So these are all directly correlated to
Wow.
the lower estrogen level. Nothing that you did or didn't do or
Body.
tried to do. It's just your
Mhm.
body, number one. And there's a very simple solution.
Wow, and that's the estrogen.
So, yeah, we can talk about, treatments now or later, but,
Yeah, I'm sorry.
it doesn't, so the thing is, it doesn't have to create such distress.
Are you able to describe to me what genitourinary syndrome of menopause is? GSM, right?
Yeah.
And why is this so many women live with the symptoms for
Yeah.
years and without diagnosis?
Right. And so this again is exactly what we talked about. Genitourinary syndrome of menopause is the impact on your vagina, your bladder, your like the external genitalia, like your clitoris, your labia, right? Women start to say, why is my labia looking smaller? Or why, do I not have as much sensation in my clitoris? Why is it harder to orgasm?
That changes?
Because
Sorry. Sorry.
it's okay, but these are all because, again, when you're, not only the internal, but the external areas lose that estrogen, your sensitivity also, you lose the sensitivity. So being able to achieve an orgasm just takes a lot longer because you
Mhm.
need more blood flow. So, to the area. And when you apply, estrogen to really allow for that tissue to like rebuild itself or, be less thin,
Uh-huh.
you want it to be more elastic and, and more, I guess, what is the word? Elastic and
Viable, but
thicker, I guess. We want that to allow for more blood flow to the area and
Mhm.
more enjoyable experience during sex. So it's not just, the elasticity of the vagina and all the tissue down there. It's not just about lubrication. It's really about also sensitivity. It's about also just vaginal health.
Wow.
Right?
Okay.
It's health. Vaginal health is not an option. It's just like all health. It's like
Yeah.
your eye health. We go see the eye doctor, right?
Yeah.
We go see the dentist, right? Vaginal health is one of the things that, and this is why I'm going to the International Society for the Study of Sexual Health in Women. Okay. I'm going this week because these things are not taught,
It's not. And
right?
then we're so embarrassed to talk about it sometimes. Like, who do we
Yeah.
talk to about it, you know?
But this is your health.
Yeah.
This is your health, right? And this is where it's like, it's not an option. It's not an option. It's part of your overall health.
That's crazy. What all right, so now let's go to the treatment. What are some treatments that you could do for vaginal and pelvic
Yeah.
health, be it hormonal and non-hormonal?
Yeah. So when I think about GSM, right, which we just talked about, so I always think about, okay, the one that is the most simple, straightforward, easiest is vaginal estrogen because that doesn't enter your, like, it has not been shown to enter your bloodstream in significant amounts. It really acts locally in the tissue in the vaginal area. So it's a very low dose,
Right.
but it tends to really work on the directly on the tissue. So it helps with creating it to a more elastic vagina. So the pain that you experience because of dryness, it
Right.
improves that. It also improves, just bladder health so that you're reducing your risk of UTIs, and some of the symptoms like, earlier onset incontinence. And it also, helps, again, as I said, it helps really try to resensitize, the tissue, the clitoris, all the external tissue. So I don't tell my patients just to insert it vaginally. I tell them to apply it externally as well to all the tissue so that, your labia, your clitoris, they all benefit from that. Okay, so that's one. And then, there are also there's DHEA. So it's a supplement that you can insert vaginally, and DHEA breaks down to testosterone and estrogen. So in vaginal tissue, you have testosterone receptors.
Okay.
Some of those testosterone receptors also help with, improving your, just sexual health along with estrogen. But it's like the DHEA is a little easier because you just insert the suppository at night and then it just absorbs.
Okay.
Lubricant, you can lose lubricants and moisturizers. Those are options as well for GSM. Again, it's not treating the root cause of what's happening, but it may help. Sometimes you get to a point where if GSM has been allowed to continue for years and years,
Mhm.
lubricants and moisturizers may not help. Yeah. But again, there's a lot of other things. And then, when I think about pelvic floor physical therapy, a lot of women aren't aware that there's pelvic floor physical therapy. And that
Right.
also will help try to bring more blood flow, oxygen to those tissues so that they can really rebuild, vaginal tissue. So that's physical therapy with a trained.
But if you're not having sex a lot and you're not using your vagina, does that also affect the dryness and certain, the tissue?
Yeah. So, I mean, you may have, because some women, dryness manifests as itching and irritation, and they just start itchy, itchy, itchy. And it's because the tissue has thinned out. So, even if you're not having sex, say that, you may be having other symptoms. You may be having, odor, there are a lot of things that can occur. So, that's why I'm saying it's not just for sex.
Yeah, yeah, yeah.
It's your health, it's your vaginal health,
Right, right.
you know?
Okay. So I know, like I said, the perimenopause affects women, but it also affects relationships as well, right? So what do you wish men better understood about their partners when they're going through perimenopause, being it physically, emotionally, and hormonal?
Yeah. That's an excellent question, and one thing I was gonna say, if you haven't watched M Factor 2, The Pause, it's a documentary that just came out, and it's gonna be shown on PBS. They have a group of men, especially Black men, okay, who are sitting, talking together about how this is impacting not only them, but their relationships. So this is definitely part of a conversation that is broadening, and it was beautiful, actually. It
Mhm.
was real, it was very real, and it was
Right.
very raw, but it was beautiful to see. And I think one thing that I think about when I look at just what, again, that whole scene
Yeah.
showed is that, it's so important to validate, your
Right.
partner, whether you understand it or not. You may not understand what's going on, but it's not about being the perfect partner. It's just being able to validate what she's going through. And then support looks like, hey, how can I support you? I don't know what I'm doing. I don't know, being able to accept that you do not have the answers,
Right.
you know, and that support one day can be look very different the next day. So
Mhm.
just having that ability to realize that it's more about connection, right? Versus correction. You're not
Mhm.
there to correct,
Right.
and so a lot of these guys were just they validated, it wasn't about we need to correct this behavior that's going on. It was like, okay, this is our relationship. We have me, we have you, and we have perimenopause in this marriage.
I love
How do we navigate this? So there was
yeah.
a lot of it was very collaborative. So I think having that collaborative approach
Mhm.
is really important
I
because
love that.
you just don't know what one day I mean, it's chaos.
Yeah.
So, it's being able to know that I don't have to be perfect, but it's like I'm just there.
Right.
Looks different, on every day.
Right. And I guess, like I said, we go through it too, but they go through as an andropause as well. And it's for both of us to understand that things are going to change, right? So we
Yeah.
have to be able to understand and navigate both our hormones changing
Yep.
and not just pointing fingers and like, why you're so angry, So I like that.
Yeah, it's coming from curiosity. It was really like, yes, curiosity versus correction. We're not gonna go about that way of correction. Let's get curious and really
I
see
love
what's
that. I love that. All right. So before we wrap up, right, I want to speak to the women listening who feels like she is failing. What would you say to a woman who feel like she's losing herself?
Mhm.
What is she really experiencing is a biological transition. What do you say to these women who are going through, who are just starting to go
Yeah.
through this?
Yeah. I mean, I think the first thing I'd always wanna do is just validate. Validate that, again, this is why I have so much fire underneath me when it comes to this because we weren't trained. Validate that this is a biological transition that your body is going through. So, what you're going through and whatever symptoms, that is data, not blood work. Data is in the symptoms, okay? So, I think, again, your body is just responding, to this transition and that it's treatable. Suffering is not a requirement. And I think what I say is that if you're not getting support, from your clinician, or the person that you see,
Mhm.
I always say it's great to find somebody who's been trained, who knows what they're talking about. But then also, I think, combining that with like a support group where
Right.
there are other women who are going through the same thing, because the magic occurs when one woman stands for another woman. One woman's be able to say, "Oh man, I have that happened to me, and this is what
Right.
I did," and
Right.
so there's hope, right?
Yeah.
There's hope that
Right.
wow, okay,
That's good.
you know? So, that's where I think it's really important for, patients to advocate if they go to a doctor where they're
Yeah.
not to ask questions or, get a second opinion,
Right.
and just realize that those are things that are available to you.
And that's what I was going to ask. Like, what do you tell that doctor? How do you advocate for yourself when you go to these doctors? But like you said, seek a
Yeah.
second opinion or something.
Well, I think it's important even if, you have your own doctor, I always say it's important to do a symptom tracker because, again, realize that you're going to come to some doctors. And if you have all these symptoms, that is data versus blood work. So I would definitely try to make sure that you, at least for a little bit of time, that you are monitoring your symptoms, know
Mhm.
which symptoms are bothering you, which ones are impacting your daily life, be able to communicate with them based on information that you have gathered. Because in the way that we've been trained as doctors is that we look for patterns.
Right.
Yeah. If you and this is the sad part, we if you come and you're like, "Well, I think I'm having this," or "I think I'm having that,"
Yeah.
you know, it's easier for them to just, shuttle you off somewhere else.
Mhm.
But I think realize that with medical training, we recognize patterns and we're able to look at patterns.
Right.
So if you can come up with, okay, this is how long, this is
Mhm.
what I've been going through, and
Ah,
these are the symptoms that are actually impacting, because you have to be able to discuss how are these symptoms impacting my life?
right.
Because if they're not having an impact, the doctor's going to be like, oh, just live with it, right?
Mhm.
But you've gotta be able to communicate that, "Dude, I can't even go to work," or "I can't, I don't wanna go to work," or "I have to take a break during my lunch break and go lay down in my car."
So
So,
something.
being able to communicate the degree of distress that these symptoms are causing you is really
Mhm.
important. So that's why I think that's what advocacy looks like is symptom tracker, being able to,
Right.
come to Chris with as much information for the doctor,
Mhm.
but then ask if the doctor offers you a treatment. I think it's just important to ask, why did you choose that for me?
Mm.
Also ask, are there any other options?
Right.
So you can be able to have time to think about what resonates for you
Yeah.
out of these options. And then if you know that that did not go well and they got defensive or they didn't, then you just, just look for another opinion.
Find another opinion. Yes. Okay. So if there's one thing, right, you want women and the people they love to truly understand about perimenopause, what would it be if you haven't touched on it already?
It can be an amazing journey of discovering yourself. Yeah. It can be truly an amazing journey of self-discovery. And I think, I look at patients who have embraced it and, because that's where the mindset comes in, when you're able to look at, wow, like this is what my body is going through, but this is a new chapter. How do I engage in a different way with who I am? It can
Okay.
be very, very powerful, very
Right.
powerful.
Wow. Never thought of it like that. Never
Mhm.
thought of it like so where
Yeah,
can people find like trusted evidence-based like menopause care? I know you said the swans, which I'm gonna look up,
the
right?
SWAN study. So, I mean, the SWAN study really doesn't talk about care, it just gives you information about the differences that
Okay.
occur in the different races when it comes to all the different metrics that they measured, because they looked at a lot of different things. They looked at your periods. How do your periods change during this transition? Like, and I think they identified that Black women, half Black women were, 50% were more likely to have had a hysterectomy, So you look at, they find all this data from, and so then the other side is now putting it together and coming up with the conclusions, which if you Google SWAN study,
So
or studies related to the SWAN study when it
mhm.
comes to either Black women, Asian women, like
Right.
that's what you would have to Google to be able to
Okay.
see, okay, people have actually combed through all that data and they were
Yeah.
able to look at this is what all
Right.
that information put together
Okay.
concluded.
So I'm gonna ask because I know we're in America, right? But is that just an American study? Is this done like in Africa or Jamaica where a lot of black is not done it, or even in Asia?
No, it's done in America, and basically, it's important. It was part of it was government funded by the NIH, part of it was
Right.
Department of Defense, which is
Right.
why they were able to have, like, over 3,000 women. So it was funded, it was well funded when the NIH was still funding women's research.
Yeah. Right.
So they really said it was the study of women across the nation, and it was the US
It was
government.
just the US.
It was just the US. Yeah.
Because sometimes I wonder in different countries,
Yeah.
are they having the same symptoms as we are in America? You get what I'm saying? But I know.
That's you know what? It's funny because I have worked in Cambodia. I did an event in Jamaica for the M Factor. And I worked in, gosh, El Salvador. Like I've worked in different parts of the world and it's really interesting how it manifests. In Asia, they have, higher vegetables, proteins in their diets. So for them, they did experience menopausal symptoms, but a lot of in the area that I was, I should just preface it with the area that I was, it
Okay.
was more mental health, symptoms and vaginal dryness.
Ah,
So, that's how it manifested for some of these women. But what part of the culture they would, as they grew older, they would eat more of the soybeans, and that just became, at least that's what I heard again within the community, that became something that was more prominent in their diet as they aged. So it was a
oh, yes.
part of aging that they incorporated,
Or
more
so. Or
soybean.
so. Okay. Okay. Wow. Okay. Yeah, I've always been just curious. I like, is it America? Is it different countries go through the same thing, or is it food that we're eating here? So that's why I asked that question because
Yeah.
I'm curious.
Yeah.
But I do appreciate you being on. Where can people find you?
Me on Instagram, like dr.kudzai. I have my website linked to my post. I'm also at Alloy Women's Health. And so that is more of a platform where they offer educational resources. So we have a lot of doctors who do webinars and they try to offer, evidence-based information, or they do offer evidence-based information, let me put it that way. And then, there are other places that you can go and look for information, like, there's the Menopause Society. They have a patient section, and there's another, there's a menopause advice hotline, that Alloy does. And they connect you with a nurse practitioner. And it's a free, I don't know how many minutes it is, but you just call if you're concerned about, okay, is this normal? Is this perimenopause? Is this menopause? They allow you to talk to a certified nurse practitioner and, you get a free, 15-minute conversation, and they're able to direct you to whatever care you need.
Okay.
It's called
Where do we
Menopause Line.
where do we find the support group that you were talking about, like for
Oh, yeah.
vaginal?
Yeah, so the Black Women's Wellness Support Group, so we've had to put that on pause because one of our co-founders, she's on medical leave right now. So we were doing it all last year, and we are brainstorming on how we can continue it, so stay tuned because it was very, very it was really it was just a magical time where we, as Black women, came together, or support, and so one was like, "Oh, my doctor's telling me I need to get a hysterectomy because," and then this one was like, "Well, this is what I did." Like, so it's just such a
That would
magical
be
time of support, like
that would be
sister
good.
support.
Right, right. Well, I really appreciate you being on Dr. Kudzai, right?
Yeah, yeah, yeah.
Yeah, I really appreciate you. Thank you so much for being on.
You're
All right.
welcome, and it was a pleasure.
Thank you so much for